Are you able to see it now?
Yes, yes.
Okay, sounds good. Our
So
paper,
maybe you have what's called the other mode, just maximize, but either way.
what's that?
So maybe there's like a presentation mode. Oh yeah, yes. Click here. Okay, good. Thank you.
Oh, 1 second. Can I leave it like this because I have notes?
Oh, that's fine.
Okay. Um, so our paper is identifying the impacts of education and health in the presence of treatment externalities by Edward Miguel and Michael Kramer. And my name is Malayla.
My name is Michaela.
And my name's Darlene.
So a summary of the paper really discusses intestinal helminth. It includes roundworm, hookworm, whipworm, and schistosomiasis. It infects over a quarter of the world's population. Studies have shown.
Just okay. Just interrupt you for a second.
Sure.
So, given most of our students coming from United States, do you guys really know what it is?
Before reading the paper, I knew a little bit about hookworm and roundworm, but
okay.
Not about
before that. So when you grew up, so you never heard about these things.
So my parents are actually from a third world country, so I've heard of them.
Okay, I got you.
But
so it is a serious problem. Actually, I grew up with this type of worm. I mean, it's like my classmate had that.
Yeah.
Yeah. All right. So okay.
Sure. So intestinal helminth is essentially an infectious disease. It affects about a quarter of the world's population. It's just a parasite, essentially similar to like tapeworm, if anyone is familiar with that. And the paper discusses the missing externality benefits of comparison groups reducing the disease. It also discusses the underestimating benefits of treatment groups. So the paper discusses a project that they conduct. A Kenyan project it's a school-based mass treatment with deworming drugs that were randomly phased into schools. They examined 75 different rural primary schools in a randomized order.
So can you explain to us what is the externality they are mentioning?
Sure. So the externalities that they're mentioning are the programs, reduce costs and stuff like that.
So what costs? Sorry, can you just explain a little bit? Yeah, sorry.
So the treatment groups that they have, that's what they're kind of discussing, and we'll go more into depth with that later.
Okay.
But essentially, that the project that they conduct is a program that reduces school absenteeism, and the treatment schools, they noticed that it reduced by over a quarter, and it was the cheapest alternative to boost school participation. The deworming essentially improves health and school participation among any untreated child in the treatment schools and the neighboring schools. The externalities that they have are like not large enough to justify any subsidizing treatment. They don't find any evidence that deworming improves like academic test scores and anything like that. So the paper breaks down between the existing literature on helminths in education, which I will go into depth with. The third section describes the project and evaluates the Kenya, evaluated in rural Kenya, and then it also presents any baseline education and medical characteristics, which Darlene will go into. And then the fifth, sixth, and seventh section describes health, school participation, and test scores. And the last section describes improving health and school participation. So the second section of the paper discusses the literature on helminth infections. So essentially, right now, currently, hookworm and roundworm infect about 1.3 billion people around the world, while whipworm infects about 900 million, and 200 million people are infected with schistosomiasis. Most people have like a light infection. Most people may be asymptomatic. A minority of people have a pretty heavy infection with it, which leads to a lot of like iron deficiencies and drugs that must be taken annually. The school children account for 85% to 90% of heavy schistosomiasis cases in Kenya, and that incorporates for 9 different villages in Kenya. The infection levels are pretty spread out. Typically, they're due to poor hygiene, malnutrition, and any other different health deficiencies. Low-cost dose therapies can kill the worms, reducing hookworm, roundworm, and schistosomiasis by about 99%. Single dose treatments are moderately effective against these cases. However, reinfection is pretty rapid. About 80% of the cases typically return back, and most people typically have to take a lot of drugs every 6 months in order to be for the reinfection to go down. The treatment externalities for schistosomiasis are typically large areas, than typical different geohelminth externalities, such as like disease transmission. Children in the area are typically infected from bathing or fishing from schistosomiasis.
So excuse me. So here, so I guess so externality. The one externality to talk about is it's like so maybe in like today's world is like a kind of community spread. So here, so they just say is if my classmate had or my friend had had this worm, and
Yeah.
so I made right.
Yeah, the externalities are like poor.
Like reduction of like a worm infection.
Yeah, so they will talk about later in the paper about how it affects neighboring schools and also the students in school that are not getting treated. Like,
right. But again, so I want to stress the importance because give most of our students grow up in the United States, so you may want to say a few words regarding to how severe it is in terms of the impact on those school children's health, health like human capital and accumulation and their impact. So you may want to say a few words on that.
So what exactly you want us to say a few words on treatment
So
externalities?
so you may want to expand to the rest of the class to emphasize or to explain so how severe is this problem, like to those school children. So for example, if I got a word, so how would that affect my health, my son, my studies, so on and so forth. So
I mean, poor health, like, and you'll have poor hygiene, anemia, stuff like that, malnutrition.
Right. Okay.
One thing
Yeah.
that does come up a lot is that typically if somebody were to like have, like later on we discuss how this can tie back to like HIV and stuff like that. And it
Okay.
correlates to like the working class. So a lot of these like younger individuals will later be the working class. And if they have like a very small working class or people that are constantly needing medical attention, then it ends up like affecting the economy and then it affects the income and health overall.
Okay.
yeah, and so the students getting affected by the worms, they will often not be able to go to school, or their like the work they can do in school is not as effective, and yeah, some people get really sick. So
Okay. Okay, thank you.
Sure. So most of these cases are waterborne cases. They're carried pretty consistent, such as like community spread and stuff. And also snails are pretty common to serve as hosts. Poor health outcomes are correlated with low income, which is one of the reasons why low levels of education and environmental risk factors correlate with receiving these diseases. And lack of access to safe drinking water, sanitation, especially in these rural areas in Kenya, are really prominent on why children get infected so commonly. The existing studies in the literature provide provisions of deworming treatments within schools. They have different placebo groups that examine the impact of deworming. They have a lot of cognitive outcomes. Most of them are positive. Within these school randomization designs, the existing studies are credible for different benefits. The difference that we see is educational outcomes. The placebo groups really discuss a lot of re-examination of these students. Most untreated placebo groups often experience a lot of load reduction. And then next, we will talk about the different deworming projects. The primary school deworming project in Kenya, and Darlene will take over.
Okay, so now we're going to analyze the project that discussed in the paper. So the primary school deworming project took place in Busha, Kenya, which is a poor and densely settled farming region in the area with like the highest helminth infection rates in the district. So the project was intended to analyze whether the implementation of treatment for worms was effective in schools. So the study consisted of 75 schools who had a total enrollment of over 30,000 students between the ages of 6 to 18. And then all schools selected had similar demographics, nutritional, and socioeconomic characteristics. So these 75 schools were then randomly divided into 3 groups of 25 schools each. So Group 1 schools received free deworming treatment in both years 1998 and 1999. And then Group 2 schools received it in 1999, and Group 3 schools began treatment in 2001. So Group 1 schools were treatment schools, while Group 2 and 3 were comparison schools, and then this changed in 1999. So on the next slide, we will further analyze Group 1. Okay, so Group 1 was a treatment school, so it was necessary to first understand the current statistics of the schools in order to determine the effectiveness of the treatment later on. So Group 1 students had more self-reported blood in their stool, reported being sick more often than Group 3 schools, and were not as clean as Group 2 or 3 schools. Group 1 also had substantially lower average scores in primary school examinations, but this didn't really become relevant in the project because there was no actual effect that the treatment had on average test scores. So when Group 1 was further surveyed, it was found that 92% of surveyed people had at least one worm infection, which can be seen in the table presented. And what they also found was that moderate to heavy worm infections are more likely to happen among younger boys. So then on the next slide, now we can see the data that was collected on Group 1, which was the implementation of the actual treatment. So each school in Group 1 with helminth prevalence over 50% was mass treated with albendazole every 6 months, and schools with schistosomiasis prevalence over 30% were mass treated with a different drug annually. So all schools ended up meeting the requirements for the treatment of helminth. On the other hand, only 6 of the 25 schools met the schistosomiasis cutoff. So schools were then supplied with the medical treatment, but girls at the age of 13 were not treated due to concerns of effects of the drugs could possibly have on their bodies. But apart from the treatment, schools also received worm prevention education through regular public health lectures, wall charts, and the training of teachers in treatment schools on worm prevention. So the overall
So excuse me, can you just explain to us how we read this table?
this table. So I was just gonna get to that one, but it's pretty much what he was trying to determine was if there was effect on transfer rates. So pretty much if people were to transfer from one school to another, it would impact the results, because if somebody who wasn't receiving treatment from group 2 schools were to go to group 1 schools, it would make it seem as if the treatment was less effective. But what
Oh, I see. So, sorry. So I see. So here just report. So throughout the study time period, so there are students who transfer from one school to the other school.
Yes.
Okay.
Yeah, he did that, but he noticed that there wasn't a very large asymmetric flows of people into treatment schools, so it wasn't it didn't really alter the results that he got.
Okay.
So
you.
so the overall average treatment rate of 1998 and 1999 was 72%. So comparison schools, a part of group 2 and 3, only received 5% of medical treatment. So this means that these people, group 2 and 3 schools, actually went out of their way. Only 5% actually ended up going out of their way to get medical treatment. So on the next slide, the study was able to show a great difference between treatment and comparison schools. So another survey was handed out to group 1 and 2 schools after treatment. So overall, 27% of people in group 1 schools had moderate to heavy worm infections when compared to 52% in group 2. So all infections were lower in group 1 schools than in group 2. And as can be seen in the table, group 1 individuals also reported better health outcomes after the first year of deworming treatment. 4% fewer group 1 individuals reported being sick in the past week, and 3% fewer individuals reported being sick often. But in relation to health education, it had minimal impact on behavior. So now I will pass it on to Michaela, who will talk about deworming projects' effect on health and education.
So formal estimation confirms that children in the deworming treatment schools experienced a range of health benefits, and the benefits even spilled over to both non-treated students in the treatment schools and also to students in neighboring schools. So the proportion of students with moderate to heavy infections was 25 percentage points lower in group 1 schools than in group 2 schools. And the within school externality effects show a 12 percentage point reduction in moderate to heavy infections. And the externality effect on schools located near group 1 schools also had a significant reduction in moderate to heavy infections. So schools located 3 kilometers away had 26 percentage point reduction, and schools located between 3 to 6 kilometers away had a 14 percentage point reduction.
So excuse me. So this seems like so the neighboring school externality is stronger than within school externality. Did they say anything about that?
Sorry, what did you say? That the
so I'm saying you look at your bullet point. Say within school externality effect is 12% reduction.
Yeah.
But for neighboring schools, so it seems like stronger. Like within 3 kilometers, 26% point reduction. 6 kilometers, 14%. So both numbers higher than 12%.
Yeah. They didn't discuss the reasons for that much.
Okay.
I think it might be because the school, the group 1 school, I think that was closer, that area was a higher, so the infection rate is higher in that area. So the
Okay.
schools that were 3 and 6 kilometers away are not, do you understand what I mean? So it's not as many people affected by the worms.
Okay.
But so if comparing group 2 to group 1, the average cross-school externality reduction in moderate to heavy infections for the comparison school was only 9 percentage points, while the effect for treatment schools was 29 percentage points. And also the results are underestimating the externality effects, since it's not including the effects further than 6 kilometers away from the school, and also children of school age that are not enrolled in any schools, and also other people living in the areas close to the schools in which the children were getting treated. So the effects of the deworming treatments are probably larger than the results from the survey shows. So the next slide discusses the treatment effects on school participation. So this section argues that in treatment schools by at least 7 percentage points, and 1/4 reduction in total school absenteeism. So just like the health impacts, deworming also created externalities in school participation, both within the school and non-treated students across other schools. So after accounting for externalities, they estimated that overall school participation in this area likely increased by at least 0.14 years of schooling per student, that actually got treated through the program. And this effect is larger than would be expected from the non-experimental estimates of the correlation between worm burden and school participation. So the average school participation increase for treatment schools relative to comparison schools across both the years of the project was a 5.1 percentage point.
So, excuse me. So let me just say a few words regarding this, so that it help us understand how important this study. So look at here. So you just report. So likely increase 0.14 years of schooling. You may have a sense how much does it cost, right? To treat each pupils. Do you have any sense how much does it cost?
Yes, it was $0.49 per person, I think.
Very, very low cost, right? But so look at this schooling, like this roughly translated into 2 months. Anyway, so right, so like 1 month of schooling. And remember earlier we show a comparison between I believe it's Argentina versus China, no? So look at their schooling, right? And over time, so I mean this like a 0.14 sounds nothing. But just if we look at history, like right, look at Argentina versus China, like over a long period of time. So like Argentina has very little improvement in terms of schooling, right? And if we put into that context, and you can see the significance of this study, because basically they find so we can spend like just less than $1 or something, and then so we can have a dramatic improvement on their schooling. So that is going to lead to a huge accumulation of human capital down the road. So that's kind of the significance of this research. Sorry, so just continue.
Yeah. So sorry, I don't know where I was. I think yeah. So as I said, the program increased school participation about 2 percentage points on average among students in comparison schools, whereas children in the treatment schools had about a 7.5% points higher participation. And the increase in participation was higher among the group of girls younger than 13 and all boys than the group of girls over 13, which is consistent with the fact that a far smaller portion of girls over 13 received medical treatment. And when it comes to the effects on test scores, as mentioned before, the differences in test results between students in treatment and comparison groups did not show any statistically significant effects, and neither did the cross-school deworming externality effects or the within-school externality effects. And the paper discussed different possibilities, possible reasons for that. But even if the deworming treatment didn't have effect on the test results, its overall health effects most likely affect education outcomes in the long run and thereby affect economic growth, which I will discuss more on later. So the next slide, which is the 8th section of the paper, was about cost effectiveness and welfare analysis. So the paper explores whether mass school-based deworming treatment should be a public policy priority for the poorest countries using 4 different approaches. So the health cost effectiveness approach talks about the deworming mass treatment is only one of many health interventions competing for very scarce public resources in Kenya and other poor countries. For example, vaccines against measles, I don't know how to say it, has been shown to be very cost effective. But summing up the effects and results by the deworming treatment, deworming would actually be one of the most cost effective health interventions for less developed countries. They also consider educational cost effectiveness of promoting school participation through deworming rather than through alternative educational interventions. It showed that deworming by far was the most cost-effective method of improving school participation among a series of educational interventions implemented in the same region of Kenya, such as evaluated textbook provision, grants to school committees, training for teachers, and things like that. And the human capital investment approach estimates the rate of return deworming has in future earnings. And given that deworming increased school participation, but not test scores, and some differences in calculations between this study and others, calculations about effects on human capital accumulations must be speculative. However, some rough calculations show that the labor market benefits of deworming, and they found that deworming increases net present value of wages by over $30 per treated child at a cost of, as I mentioned earlier, of only $0.49. And the externality approach shows that the externality benefits of deworming in terms of future wages alone appear to be way larger than the cost of deworming. So the total net externality gain is calculated to be 15.9 per child treated, comparing to, as I mentioned before, the cost of $0.49. And also, as I mentioned earlier, the externality effects are most likely even underestimated, since the school doesn't include potential benefits experienced by kids in the school, in school age that are not enrolled in school, and other people in the area that were not included in the survey either. So to connect this back to chapter 9 from the book, if we go to the next slide, the paper talks about how there are large literature documenting on positive correlations between health and economic outcomes, which relates back to the book, as I said. And the book discusses how there is no doubt that there is a positive relationship between the two, but that the question is what is causing what. So basically that increases in income and reductions in poverty could lead to better health, but that there also could be better health leading to faster income growth, higher income, and less poverty. But like I think most people would guess, it seems like it works both ways. So health improvements leads to faster economic growth, leading to higher incomes, and higher incomes lead to even better health, which goes hand in hand what is discovered, discussed towards the end of the So the paper also discusses increasing income on health and economic growth and how it's all connected. And if we go to the next slide, it talks a little bit more about income and health. So when income increases, households and individuals and even society at large are able to buy more of a wide range of goods that either directly or indirectly improves health. And some products include more and better food. So there is a strong causal link between higher incomes to improve nutrition and improved health, and also clean water. With higher incomes, poorer households can more easily afford clean water and basic sanitation facilities, which also can help control diseases, like the different types of worm infections. But also better shelter. So when income rises, poorer households can afford better shelter, which in turn will improve their health as well. And they're also more likely to be able to seek healthcare. They will both be able to pay for transportation costs to clinics and pay for medicine and things like that. And it also affects the society as a whole. So as income rises, there are greater ability to build public health clinics and hospitals and train more doctors and nurses, and also pay for public health services such as immunization campaigns or insect spraying programs, etc. However, poorer countries cannot afford to build the same type of healthcare systems and are often not able to pay doctors and nurses enough money to keep them from moving to other countries before being able to build up a good base, which leads to not having as good resources. Now I will pass it over to Darlene that will talk a little bit about how the paper relates to other topics discussed in chapter 9 of the book.
Okay, so as a result of this paper, we are able to have a possible answer on how to implement its findings into other developing countries. So this paper then ties back to chapter 9 in regards to the 3 developing world's most prominent and deadly infectious diseases, which are HIV/AIDS, malaria, and tuberculosis. It ties back on a possible answer of how to effectively lower the rate of infected by these 3 diseases. So to quickly overview how deadly these diseases actually are, on average, about 4.5 million people die of these diseases a year. This accounts for about 8% of all deaths worldwide. Compared to high-income countries, the death per capita of these diseases are 23 times greater in developing countries. This results in tremendous economic loss and social disintegration. So luckily, with the project done in the paper, it gives a possible answer on how these diseases can be treated effectively. So now let's analyze each disease and their impact on developing economies individually. So on the next slide, we're gonna first further analyze HIV. So currently, HIV is the leading cause of death among adults aged 15 to 59 worldwide and has killed an estimated 25 million people. So sub-Saharan Africa bears the largest burden with 2/3 of the world's infection, even though it is home to only 1/10 of the world's population. In
So
sub-Saharan,
excuse me, are you supposed to like show the next slide or so?
oh yes.
Sorry, yeah, thank you.
So in sub-Saharan Africa, about 1 in 20 adults carry the virus. So now HIV can have a huge toll economically on countries such as those in sub-Saharan Africa. So as can be seen in the graph presented, life expectancy dropped from an average of 61 years in 1992 to just 47 years in 2007. This is damaging because for countries such as those in Africa, the lives that are most impacted by these diseases are society's most productive members. As a result of this, families become further impoverished due to not being able to work because of sickness. Therefore, countries take a huge hit economically. So on the next slide,
Please, next slide. So so your members, so your team members controlling the slides, right?
Yes.
Oh, good. Very good. Thank you.
So the same results can also be seen in relation to countries whose population are being affected by malaria. So at the moment, it is predicted that half of the world's population is at risk of malaria in over 106 countries. This is due to the fact that malaria claims the lives of 2,000 children every day. Not only that, but malaria contributes to almost 800,000 deaths and 225 million cases of severe illness each year. Africa, again, bears the heaviest burden with about 78% of the cases of clinical malaria and 91% of the world's malaria's death. As you can see in the graph, malaria has a disproportionate impact on the poor. This is troublesome because the poor are less likely to be able to receive treatment for the illness. The same impact of HIV can also be seen in countries whose population is affected by malaria. Life expectancy is lowered and income is affected as a result of it. So then on the next slide, we can analyze tuberculosis. So over 2 billion people are infected with tuberculosis. On average, about 1.7 million people die of tuberculosis each year, and 90% of those deaths occur in developing countries. So similar to HIV and malaria, tuberculosis affects the most productive members of a country's ability to work. So as a result of this, research has shown that tuberculosis depletes the incomes of the world's poorest communities by up to $12 billion every year, and lost productivity can cost an economy on the order of 4 to 7% of GDP. So on our next slide, now what can we conclude from analyzing HIV, malaria, and tuberculosis and their impacts on developing economies? So a popular trend among all three diseases was that they primarily impact the poor. As a result of this, lowered life expectancy was a frequent occurrence among countries whose population was impacted by the disease. This further resulted in increased poverty because a country's working class was typically the ones affected by a disease. Now, the reason why some countries are so greatly impacted by such diseases is due to the lack of funding to provide people with the adequate resources and institutions to get treated effectively. For example, it is found that in order to effectively control malaria, it requires over $5 billion US annually, but they have only raised 1.8 billion US dollars. So if countries were able to improve their country's health through funding, children could remain in school and workers could go to work in order to help the economy. Along with this, better health would increase the opportunity nations and individuals face to save and invest in their futures. In turn, higher incomes would permit governments and families to devote more resources to improving health. Therefore, through the analyzation of these three diseases, we are able to see that HIV, malaria, and tuberculosis are preventable, and with adequate resources and institutions can be treated effectively. But this is simply not happening, which causes economic failure and human tragedy. Luckily, the paper examined provides us with an answer on how to not only effectively treat individuals affected by these three diseases, but also a cheaper method on how to do so. If areas affected with these diseases were to implement treatment into their schools, as a result, it is possible that we could see similar results as the project regarding students infected with worms. So just to quickly recap, today we discussed Edward Miguel and Michael Kremer's paper entitled Worms Identifying Impact on Education and Health in the Presence of Treatment Externalities. So overall in our discussion, we were able to learn that the project provided a possible solution on how to address disease growth in developing countries by implementing treatment into schools. But one thing is for certain that we did see by analyzing the three diseases was that if we do not effectively solve the problem that developing countries are currently facing, then people will continue to die despite the fact that treatment for many of these diseases is available. So that's it.
Okay, so really good, wonderful. Thank you so much. So I mean, this lots of presentation. So you really have done a lot of work, and so you also connect to our textbook in almost like a perfect way. Thank you so much. So okay, so that concludes our group presentation. Please send me your slides, and then so I can assign you a grade. And so I may just pause your slides for the future students. So yeah, okay, thank you so much. So now so we have roughly like 10 minutes. Let me just quickly explain to you what are we supposed to do with this one. So this question. Oh, okay, so where's my right here. So the first question, right? So I already explained to you how we solve the first problem, right? So now the second one, so let me explain to you how we do the second one. So use a diagram to explain the following two things. Number one, the impact of income growth on household choice of a number of children. And then number two, the impact of closing gender wage gap on household choice of number of children. Right. So now let me just go use my notepad to explain to you how we work this out. So essentially, this is going to rely on the diagram we studied earlier. So that explains the choice between the numbers of children you would like to have versus regular consumption. Right. And so certainly there's a budget constraint. Right? So this budget constraint reflects the cost of raising child, right? So this cost essentially is opportunity cost. Opportunity cost, okay? And think about in the question in our homework in the second part is ask you, so what happened if the gender wage gap is closing? So actually, so that increase the opportunity cost of having more children. Why is that? It's because so if you have more children, and then so the wife must stay at home or more likely to have to stay at home. But now so you have a closing gender gap in wage rate. So that just means so the wife must give up a larger take-home wage. So that's the opportunity cost. Right? So this slope of this curve essentially is going to reflect the opportunity cost of having more children. Right? And then so we have this indifferent curve. This indifference curve just what? Just shows you what is your preference between consumption versus number of children you're going to have. Right? And then they cross each other. That's going to give you the optimal choice. Now, in the first case, if there's an income increase, and then so that just means so we have a extended. So we have this, right? So we have budget constraint will shift outward. So that just means so we can potentially see. So both consumption. So convert this point. So both consumption and the number of children you're going to have will increase. So this is what we call income effect. And this combined with the fact that both consumption and a child, so they are normal goods. All right. So now we go to the other case. If the wage gap, sorry, the gender wage gap is closing. So that just means essentially means the let's use black one. That just means here. It's become more and more expensive to have one additional child, right? Because opportunity cost increase, as I just explained to you. That means so the optimal choice may change from here. So let's use a slightly different color. Let's see, red. All right. So then clearly you're going to see, so you're going to increase consumption, but decrease the number of child you're going to have, right? So this is due to the substitution effect, right? Because here, so we are going to look at C and the number of child. they are substitute for each other. Now, so it becomes more expensive to have a child, and then so you want to substitute consumption for child. Now, in a very crude way. Okay, the cost of this change is because the opportunity cost of raising child increase due to the increase in foregone take-home wage, right? So that is for our homework. Let's see. So, is there anything I need to discuss? Right. So that's for 1 and 2. Right, 1 and 2. For 3, so that is pretty straightforward. Just use words to explain a few concepts. Right. So yeah. Okay. So that's sort of things. Any question?